Today's Imprint Weekly podcast is brought to you by Accenture. Change is afoot in child welfare. Change that means agencies focus on results for children and keep far more of them safe at home with their own families. Accenture's child welfare team is leading the way in the effort to ensure technology does its part in that success story. Accenture offers cutting-edge case management tools that ensure agencies can see insights that drive decision-making and caseworkers have information they need at their fingertips. Together, these tools help agencies stay laser-focused, reinventing child welfare into a source of strength for families when they need it. For more information, visit www.accenture.com/childwelfare.
Hello and welcome to the Imprint Weekly Podcast. I'm John Kelly, Senior Editor of the Imprint, a daily news site covering child welfare and youth justice around the country. You can read all of our coverage at imprintnews.org or check us out on Facebook or Twitter at the Imprint News. You can sign up on our homepage for our free weekly and monthly newsletters. And for professionals in child welfare and youth justice, subscribe to our Youth Services Insider section for a closer look at news on business policy and practice. The Imprint Weekly Podcast is also a member of the Safe Camp Audio Network. Check out our show page and all of Safe Camp's other great podcasts at safecampaudio.org on the web, at Safe Camp Audio on social media. So we've got an interview-only episode for you today. We'll be back with headlines and analysis next week. But this week's guest is an extremely great one, Kathy Icenhower, co-founder and CEO of Shields for Families, which is a Los Angeles-based organization that was literally decades ahead of its time in helping parents remain with their children while working through serious substance use disorders. We'll talk to Kathy about how this program went from a little trial balloon in a condemned trailer that the county gave to them to a major provider in Los Angeles. We'll talk about her concern about the recent trends in treating addiction in the U.S. and on leading a nonprofit for as long as she has, and much more. We'll be back, like I said, with headlines and another great guest next week. Without further ado, here is our conversation with Kathy Icenhower. All right, we are joined today by Kathy Icenhower, CEO of Shields for Families. Founded that organization more than 30 years ago, now in Los Angeles with Norma Ntume and Dr. Xylina Bean. Also a member of the Ohio State University Social Work School Hall of Fame. Kathy, thanks for joining us on the Imprint Weekly Podcast.
Thank you for having me.
So we got to get these folks to know you a little bit before we start talking about your career and what you think of the current moment and things like that. So let's give them at least one favorite. Here's your categories, Kathy. TV show, movie, musical group, book, or sports team. You only have to give me one. You can give me more than one, but what do you got?
The Ohio State Buckeyes. Anybody that knows me knows that I am a fanatic Buckeye.
Did you grow up in Ohio?
Yes, I did.
When did you move to the city you would call home and have been serving for so many years now?
In 1979.
Did you move there to be a social worker? Was that like your first gig when you got to LA? Was working on the streets and doing that stuff?
No, I worked in Ohio. I got my BSSW from Ohio State and worked in Ohio at the Women's Reformatory. That was a maximum security prison for women. I worked there for a couple years, and then I applied for graduate school at USC and got accepted. And so moved out here to get my MSW and ultimately my PhD from USC.
So I know from doing my homework on you to prepare for our interview that the story of Shields begins in an abandoned, condemned trailer. But yes. I want to start even before that, because I don't know. I would love to hear from you sort of like about the work you did in Los Angeles that crystallized, like, I want to do this, and tell me how your cohorts, your co-founders came into the mix. So tell folks a little bit about this. We're talking in the 80s, late 80s, right?
Yes. Yeah. Yes. Well, starting in probably the mid 80s. I mean, you talked about working with homeless families. So I did a lot of work for my church. I started a homeless families program there that was in Hollywood at the Hollywood United Methodist Church. But since I've been out here, because I wanted to go into criminal justice, actually, when I moved to LA to continue the work that I had done. And in the prison, what I realized is that most of the women that were there due to substance abuse related issues. And so when I came out here and I found that you had to be a guard first, I decided that maybe that was not the thing for me.
Is that
And
true?
so
You had to be a guard before you could do anything else?
before you could be a social worker, you had to be a guard. I don't know if that's still the case. I've heard that it is, but yes. And so I went into the next related area in the substance use field and worked in several places. But ultimately, the path that led me here is I became a children's services worker for the Department of Children and Family Services and was working doing ER for half the county then, the way that things were settled. And again, kind of the same issues. And that was at the very beginning of, what would later become the crack epidemic. I got recruited by LA County. At that time, it was called the Drug Abuse Program Office. And I took over as the head of the planning and program development department there. Knowing the problems in the community from working at DCFS and the work I'd done in the substance use field, I knew that there were no resources, particularly for women and their children. So began working on programs through the county at that point in time in order to kind of increase those services. We were able to get what was called then one of the Night of 20 grants to start a residential program for women and children. But the biggest gap for me was that there were no outpatient services that were available that could help keep families together and not have to call in the Department of Children and Family Services, not have to remove children. So I designed a model, which now is commonly called family-centered treatment, where women can come to treatment and bring their children with them and have services on site. I tried to get it funded through the county. I went to the state, and I'll try to make this story short. But when I presented it to the state alcohol and drug program office at the time, they literally laughed me out of the office. They said that this
Nobody
model,
had done this, right? I mean, you guys, I don't want to shine you up too much, but you guys literally invented the idea of what if we could have a place where mom could get clean, do what she needed to do, while also living with her kids in a somewhat controlled environment, so people felt okay about
well,
that.
in this case, living in their own homes,
Or that,
right. And they come to treatment every day, bring their children with them to treatment, and to provide on site a child development center, an after school program for the older kids. No, it had not been done at that point in time. There were some limited availabilities with residential programs where they could bring maybe one child, but that child had to be like under the age of 5, etc. We didn't want to place those limitations on our moms. Our moms had more than one child. They didn't necessarily conveniently fall in the age range of 0 to 5. So I wanted to do something different. But as I said, I was literally laughed out of the office saying this will never work. Women won't bring their children, et cetera, et cetera. Little did I know that at the same time that Xylina, Dr. Bean, and a couple of other physicians here that did pediatric work were going to the California legislature saying we have to do something. The number of children being born exposed to substances is out of control. We have no resources, etc. So the alcohol and drug office was posed with now that they had to come up with an idea to serve this population. And it just so happened that, of course, I had just been up there providing them with a model. So they agreed to fund it. They identified several pilots, 5 pilots in the state, 2 of them here in LA County, one connected to the hospitals that 2 of those physicians were from, Dr. Xylina Bean and Dr. Xylina Bean. And that's when Xylina and I met and formed our partnership. And I decided to leave the county and to go start Shields for Families.
Yeah, so it was really born in this. I don't mean to oversimplify this and like you guys, the other side didn't care about the other, but it was kind of forged of your concern for the parents and Dr. Bean's concern for the babies being born.
Yes, pretty much. Yes. And if anybody knows Xylina, then they'll know that she is not the easiest person in the world to work with. She's one of my dearest friends, but yes, she very strongly was protective of the children, and I probably was the same way in the opposite direction, very strongly protective of the moms. And we made a perfect match for each other. We'll put
That's
it like
amazing.
that.
That's really interesting. So there's must have been some testy conversations that ended with like, oh, wait, we agree on the solution.
Yes. Yeah.
Since you were working for DCFS at the time, what was your recollection of sort of the atmosphere and the mentality of the workforce that you were a part of as the crack epidemic really got into full steam in Los Angeles? I mean, was it anger at parents? Was it empathy, but feeling like I can't do it? Like, what was the general, how would you describe it?
How would I describe it? Well, it was more like we have no idea what to do.
Yeah.
But I think there were a combination of things going on because I worked for the department in 1985. And if you recall, the department became a department in 1984. The other piece of this, and, as we have discussed, I pretty much say it as it is. But at that time, most of the emergency response workers were folks who had transferred from being like an eligibility worker. So they were not social workers. They did not have that training or skill set. There were very few of us that were MSWs that were working ER. And so again, folks didn't know what to do. And back to the resources, there really wasn't much available, particularly specifically for women and their children. And because there was a lot of fear, if you recall back at that time, folks were saying things like these kids are going to be the next Charles Mansons. They're going to be, there was so much fear around what the impact of cocaine was going to have on children. I think we have now very clearly learned that with intervention, there doesn't have to be any real impact on a child.
Right.
But at the time, folks were very fearful. And so they did not want mothers to have those children. They thought they needed to go to foster care. And so pretty much every child born substance exposed was going directly into foster care. And because there weren't enough foster care homes to, put these children in, I mean, children were going to Palmdale and Lancaster from South LA, which then, of course, pretty much precluded any kind of reunification efforts with the mothers, and I honestly feel we still feel some of the impacts of that time because at Martin Luther King Hospital alone, there were over 1,200 infants born annually during like that period of time that were substance exposed. And until we started implementing some of the services, all of those children were going to foster care.
Yeah. And for the non-Angelinos listening, when Kathy says, they were taken from South Central LA and brought to Palmdale, Los Angeles County, that's like literally over a mountain. It's extremely hard to get to if you don't live there. So it's not
by bus. Yeah. By bus, that's a 4-hour venture, just one way.
Yeah.
Yeah.
And so I just I knew about the trailer because I listened to a really great radio interview you guys did a while back where the host asked, to kind of teed you up by saying, and then the county gave you a facility and you laughed a lot.
Yeah.
So it's truly just a trailer, like an RV type trailer.
It truly was a trailer. And it was an abandoned trailer, and it truly was condemned. I mean, literally, the county had condemned the trailer, and we used to laugh because when it rained, I swear that it would rain harder inside than it did outside. And I used to have to tell people that came into my office not to lean against the wall because they could literally fall through. In our kitchen area, there was a big hole you could fall directly down underneath. It was an adventure. We'll put it like that. This was like
through the administration, or you actually had clients?
That's where we had the program. Yeah. Yes. I mean, that's when we first started, when it was, it started with just me in the trailer, putting together the furniture and trying to get things going. We eventually got some funding and were able to redo the trailers. But yeah, that first couple of years were definitely an adventure. And we would call the county and say, we have a huge leak when it was raining. And they would come over in their yellow, raincoats and walk inside and say, yep, you're right.
So gritty. What a gritty beginning. I hope somebody kept the trailer. That should be in the trailer Hall of Fame next to the one from Breaking Bad. And
they ultimately rebuilt that into a building.
So from this trailer emerged, one of the most important contributions, honestly, to child welfare intervention, I think that we've seen, because especially when you get down to the discussion about why kids come into foster care, I don't think there's anything that decision is more tied to than substance abuse. And so, you guys have built a model, and I think we could probably spend, 2 hours or way more talking about all the things that go into all the services you do. So we can't do that. So I'm hopeful that maybe you could, for our listeners, kind of boil it down. What are the specific things, that are most core to your guys' approach that in your view must be present to effectively support a person, a parent who wishes to stop, dangerous drug use?
Well, that's a hard one, actually. But because I think it's a combination of a whole, is like all of those things together. But again, I think it's a safe environment where mothers can feel comfortable bringing their children there, having the staff available to have, I think, an on-site child development center where we're not babysitting for these children. We are doing assessments. We're developing individual education plans for them. If they are in need of any special services, we're making sure that happens. But more than anything, we're helping to, assist with the parenting and learning parenting skills. It's probably not a surprise to the audience that many of the women that come into treatment, they come from generations of substance abuse, or they have often been in the child welfare system themselves, and they don't know some of the most basic parenting things. If I can share a story, I learned this the hard way. When we started, it was September of 1990 is when we opened up Genesis, our very first program. And, as we came close to Christmas, we wanted to make sure all the kids had toys and all of those things. We had a Christmas party, and we went to sing, it sounds silly, but we went to sing like basic Christmas carols, jingle bells, just very basic things. And not one of our mothers knew those songs, as I explored it further, I found out that just like all of your basic things, I think most of our parenting classes, they assume a level of knowledge, when you go to teach them. And what I realized is that we had to throw that out the window. We really had to start at the very, very basics, like what should you feed your child? We had a mom who, with no ill intent, was trying to feed her child at 6 months McDonald's French fries, and no idea that was not an appropriate thing to do, so I'm just talking the very basics of how you do parenting, and again, that first Christmas, we had gotten, fortunately, like a whole donation of Barbie dolls. It was our moms who wanted the Barbie dolls because, again, they had not had that opportunity to have toys, to play with toys. And so I think that's another critical piece of what you need to understand is that in many times our parents, we have to allow them to be children also, to engage in that play experience so they can learn how to do that with their own children. I think you have to also make sure that, as I said, that we don't assume or make our moms make choices about what children they can bring to treatment with them, that the entire family has been impacted. So to be prepared for, older children, the partner, whether that's dad or whoever that partner is in the home, that everyone needs to be able to receive services. In our case, we made sure also that we removed any barriers to providing treatment. So making sure we provided lunch, or other meals if those were necessary, making sure we provided transportation. Our older kids who went to school, we made sure that they got there in the morning and we would pick them up after school, also in order to make sure that they can then come and participate in the treatment services. Ultimately, as we, grew and went down the road, our even older children, our high school age kids, we realized the impact that, I guess I should say the negative impact this had on their lives and their ability to finish school and move on. We ultimately started charter schools. And so we have 3 charter high schools now that work with the older youth. So they have a place to go, and focused on making sure that they have mental health supports available at the school the entire time that they're there, wraparound services, as well as making sure that we can then assist them with moving on to college or trade or whatever it is that they choose to do.
So Shields works, we're talking about it. This is a podcast for a news site that covers a lot of child welfare and juvenile justice. I know that you guys serve clients, obviously, that come directly to you, right? Like, it's not just your clients are not all referred from DCFS or anything. But what happens when somebody is referred to you and your assessment is that they don't have an actual problem with substance abuse? It occurs to me that it probably happens quite a bit, right? That somebody, in a world where I'm not totally dispersing, DCFS in LA for this. I think there's a problem in plenty of places. Cookie cutter syndrome. It's like drugs is present, drug treatment is the answer. That's not the key. The occasional drug user doesn't need what you just described as much as an addict would. So what happens there? Are you empowered to push back?
Yes, we are empowered to push back, and that's what we do. One of the things also is we have staff that are at the juvenile dependency court. So if this case has actually been opened, and we fight through the court system, we fight back through the social worker and the regional office, wherever the case is located. But yes, and it has happened. I'm going to be honest, it doesn't happen as often as it used to. What used to happen on a routine basis is that when moms had a history of substance abuse, then folks would report a child when they gave birth to another child, even if there was no active use during the pregnancy at all. The child had no symptoms when it was born, but they would still come in and take the child, regardless. This leads to another funny story where I blocked the door from the social worker. And when I was
trying to remove a kid.
I was trying to remove a child. Yes. So, but yeah, we will definitely advocate. We'll put it like that. Yeah, we will definitely advocate.
Kind of going in the other direction. I mean, I know that your work and your career has been focused fiercely on keeping families together whenever possible,
Yes.
But you've worked on the DCFS side, you've worked for CPS, you've done this work for 30 years. So I think your answer is an important perspective to hear on this. When in your mind is it appropriate for an agency to remove a child as a direct result of a parent's drug use? Like, what needs to be present for you to say that that's a valid thing to do?
When you cannot step in and mitigate the risk to the child. I mean, number one, in my mind, there has to be some risk of significant harm to that child in order to remove it, and no ability to put a plan in place that would mitigate those risks in any way. If a parent is using and that child is left at risk and they're refusing to access resources, again, it's a hard question to answer because there are so many individual factors. So when I'm saying you can't put a plan in place, that there's no kin available, there's no, other significant other in the picture, there's no way to make sure that child is safe, then I think it's appropriate. But I probably have seen that situation no more than a handful of times over the 30 years where there could not be something put in place.
Are you a professional in the field of child welfare, juvenile justice, or other family and youth services? Subscribe today to Youth Services Insider, the imprint's exclusive section on all the insider news you need to stay in the know. Funding opportunities, major federal and state policy shifts, interviews with key leaders in the field. It's all available only for our Youth Services Insider subscribers. Sign up for a monthly or yearly subscription today by visiting imprintnews.org/subscribe. Our podcast listeners get 10% off their subscription by entering the promo code podcast10. That's imprintnews.org/subscribe and get 10% off your subscription by entering the promo code podcast10 today.
What has changed about treating substance use disorders in general, but in particular for parents in these many decades? Like what's come up that's changed the way you thought or your guys' model?
Well, unfortunately, over the last few years, the thing that I think has been a barrier, it has been kind of diverting us away from what is needed, because the research clearly shows that, of course, comprehensive services, family-centered treatment, that you have better outcomes when that's the service you provide. All of a sudden, there has been kind of a shift to move, unfortunately, back to where we started in substance abuse. And that is a medical model of treatment. And by that, I mean thinking that all we have to do is treat the addiction itself and not address anything else that's happening in that individual's life that got them there. Just say no pops into my head at this point. And I think that that's a mistake in the direction that we're taking. I've seen its impact in California and in other states because of some of the, groups and organizations I'm involved in. But when you can't provide comprehensive services, when you can't address the issue that instigated the substance use, which is usually, due to some trauma of some sort, then that person is just it's going to be a revolving door for them in treatment if that's what they choose to even try. While I believe that is good to integrate, behavioral health and healthcare services, you can't take away the addressing of the other issues, because it's just not going to work. And that's what we see. If we can't provide comprehensive services for the length of time that an individual needs it, and that's going to vary. But if you got somebody who's been using for 20 years, to think that they can recover, and I'm in quotes, recover in 90 days is a ridiculous assumption. Their life pretty much has been, in shambles at that point. They may have barely worked or never worked. They may have not received their high school diploma. They may have lost their job. All of those things take time to address. And, if we are going to be successful, then we need to have the ability and the opportunity to work with each individual as long as they need to be worked with, as well as work with their family, and so the medical model and using Medicaid as our basis for funding has really put restrictions and limitations around that.
I don't want to assume I know what you mean by this. When you say a medical model, when I hear you say that, all I can come up with is you're talking about treating the dependency with methadone or Suboxone like a medication. But what is the medical model that plus something else that I'm not thinking of?
Well, what you just described is one approach that people are taking. For example, even just like a year or so ago, it used to be mandatory that if you prescribed a medication as one of the treatment interventions, that you had to have counseling with it. That has been removed now. So you can just provide medication. Mm-hmm. But when I talk about a medical model, even what I'm talking about is your services, like all the services we just talked about for the family. Those are not a part of the medical model.
Right.
It really is just focusing on, I'm going to teach you about what drugs do to you. I'm going to talk to you about relapse potential. I'm going to, again, really focus specifically on addressing the addiction itself. With, yes, we're now going to, instead of having these services available here at our treatment site, we're going to link you to somebody who's going to help you with vocational services, or we're going to link you with, again, multiple linkages to other places to address the other issues that you have. I personally, have been through that originally. It's why I fought hard to change how we did things. Mm-hmm. I know that it works better if you provide the comprehensive services on one side. And so it is just frustrating for me that I see us going back in that opposite direction now, especially since we have all the data and all the research from SAMHSA, NIDA, et cetera, that shows that comprehensive services actually work. So
I'm sure that you guys have plenty of clinical psychiatrists on the staff.
Yes.
Are you able to provide, what's called MAT, medication assisted treatment, in the context of your approach? Which
yes. Yes, we are, and fortunately for us, we have not seen the opioid crisis here in South LA that folks have seen elsewhere. Not that we don't have some clients who can benefit from that, and we do have it available. Because just to be clear, MAT is really about opioid use and alcohol use. Right. And so it doesn't work with the other drugs. And still in South LA, methamphetamine, cocaine, they are still the primary drugs of choice.
Yeah, I guess I was like, I'm not from LA. I'm talking to Kathy from my home in Detroit, but my stepsister was a nurse in Los Angeles for a long time, and she hit me to that. She was like, meth is the problem.
Right.
Okay, so the Family First Act was passed in 2018. I'm switching gears a little bit on a dime here. And, the bigger contours of that were more federal money for preventing the use of foster care, less congregate care of just kids. But the kind of less heralded but very important piece of Family First is that funds could flow through this, child welfare entitlement, Title 4E, for, group care of parents and kids, right? So this thing that you guys literally invented now has this imprimatur of federal funding. Has that started to have an impact in California or nationally, as far as you know? I mean, are you seeing, now that federal tap's been turned on, more interest in what you guys have built in terms of the residential approach that some parents need? Not everyone that you work with, but some.
It was a great day. And in fact, I actually wrote the definition of family-centered treatment that went into the act. And
Did you? That's cool.
Yes.
Wow.
Yes.
Who asked you to do it? How'd that happen?
I was working with a group called the Rebecca's Project, and this is with Senator Hatch's office way back when. And so we were one of probably several advocate groups who are really pushing for family-centered treatment to be a part of the legislation when it ultimately came out. So yeah, I was asked to craft some language, and that language is pretty much looks like what I wrote. still in the legislation, and yeah, we were very hopeful that was going to be of real assistance, and in some places it is. I worked with an organization for a long time, Treatment Communities of America. We did a lot of input into the legislation, and unfortunately, not a whole lot of states have actually implemented. The funding uses Title 4E funds to pay for the children, would pay for the children. Right. And like in California, they haven't quite figured it out yet. They continue to discuss it. The state where I do know that it was implemented almost immediately was Utah. And I will tell you that it has, it's saved multiple programs and allowed them to continue to provide services to women and children. And so where it has been implemented, it's been of real benefit, especially in alignment with what I was just talking about, where a lot of the states are going to Medicaid as their base payment. And Medicaid does not pay for any services for the children of parents who have substance use issues. And so
is your opinion that Medicaid you should be able to spend Medicaid dollars to provide residential treatment for parents with their kids and in substance abuse recovery?
That would be a wonderful thing. Yeah. Yes.
Little controversial, right? Because I mean, Medicaid, the whole point is that they wrote the rules around Medicaid to avoid it being able to be used in institutions because there was a righteous that we would throw into institutions. So you feel like this could be that should be an exception we're not going down this crazy rabbit hole, but the IMD exclusions, you think it should be added?
It would be a wonderful thing, but there is, I worked on the IMD exclusion for a lot of years. And so, yeah, there's the great fear that if that door is open, that, an enormous amount of money is going to be required to, fulfill it. I guess my thing is if folks really looked at the cost of not treating the substance abuse in our criminal justice systems and our child welfare system, et cetera, that money would actually be a drop in the bucket if we used it in this manner. But that, again, my own personal opinion. I also was hopeful that states would utilize, I guess, the rest of the Family First, Part 1 legislation as an opportunity to support, particularly on an outpatient basis, funding for children who are in need of services with parents who have a substance abuse issue. I haven't really seen that happen anywhere either. There may be some states that are looking at that. I continue to kind of push that concept. But, again, I think there are things that we could do with Family First that could support the SUD treatment system. But right now, I haven't seen much happen to help that occur. I'll put it like that.
The first time I ever met you in person was actually at a journalism class. I don't know if you're going to remember this, but we used to have a thing that was part of the organization that was called Journalism for Social Change, where we would teach journalism students about social work and kind of vice versa. And you came in and talked about Shield's work, and you were really stressing the fact that for some parents, for a lot of parents that you guys worked with, particularly, and I think you were mostly focusing on your residential program, which is Exodus. It's called Exodus, right? It would take 3, 4, 5 times with Shields to successfully get them to where they were clean and on track and not coming back to you. From your perspective and your experience, whether there's a rhyme or reason to which parents get multiple chances like that versus the ones that maybe lose their kids real quick and start to face termination of parental rights. Because it occurs to me that must be the case, that you see some parents where like, man, I'm glad they let them keep coming back to us. I do think that we're going to make a difference eventually. And some where they don't get that chance.
I think the rhyme or reason comes down to like, who is the CSW that goes out to their house, unfortunately, sometimes, because I don't think there is a rhyme or a reason. I mean, again, just in my experience, what someone I think would think the most unlikely mom to make it are the ones that do, and so everyone should have as many opportunities as they choose to take, and we should be there to try and do whatever we can. We know kids do better with their moms. We know kids do better with their parents, right? I shouldn't just be saying moms because it's the same with dads. We know kids do better with their parents. And so we should be trying to do everything we can to support those families to stay together. That's just my opinion, right? But I just feel like be a much better world if we focused our energies that way.
I was wondering whether your answer would be what you said, which is, kind of the saddest, that there's no rhyme or reason, and it's a lot to do with just what the worker in front of them.
That is true.
Filters. Or maybe, that people that maybe they're in a pretty dysfunctional point in their life, but had a good family network and identified, network of kin around them, tend to get more chances than somebody that doesn't have that. But yeah.
I wish I could give you a solid answer, but again, just in my experience, there has been no real rhyme or reason, and more than anything, it does come down to, like who happens to come out, what their opinion is, their implicit bias. I haven't understood sometimes why children were removed.
Yeah.
I still don't understand. I mean, we still deal with this. We have moms that are coming to treatment every day. We know that this is a disease where relapse is just a part of the recovery process. They relapse one time and they step in and remove their children. And they're coming to treatment every day. See that? Is that child really at risk? I don't think so. But yet that's again, we cycle back around where that's what we're doing. And, that's why I am hopeful that with these changes that we can finally put something in place that is going to be a permanent way of how we respond to things. Over these last 30 years, I've seen our system swing from one, direction to the other. I was a part of points of engagement here in LA County, and that was an exciting time because we were able to go out. We reduced out-of-home placement by over 60% in like 18 months because we went out and we helped families mitigate the risk in their home and kept their children together. And then we went through the next cycle where now we're removing everybody again because of fear that something is going to happen to a child. And again, my opinion, if a parent is going to hurt their child, and that's their, we're probably not going to see that. We're always going to see that after the fact. But those situations are so rare in the scheme of things. Why shouldn't we be putting forth every effort? And I'm not saying take our eyes from, but put together safety plans of safe care. I mean, it's written in their name. Put together a plan that mitigates those risks, that has eyes on those children. But that doesn't mean we have to remove them. That doesn't mean we have to open a case on them. There are other ways to do this. I mean, it takes a village, right? There are ways that we can do this and make sure that those children are safe and keep that family together and help them move to a healthy, functioning place. So,
last couple of questions for you here, and I not as sexy maybe for some, but I think important to ask you because it's pretty rare that you have a person who's led an organization for as long as you have in this space and doing the kind of work where the secondhand trauma has got to be unreal. But I think first off, as an executive who started taking clients in a trailer, and now you're the head of this 25 million or whatever it is budget organization, how do you stay plugged in? How do you make sure that that client of yours, the parent, the kid, is getting served the way you originally conceived of it with your co-founders?
That's an excellent question, actually. Oh, one of the ways that I do that is one of the first things I did when I started Shields is I started a consumer advisory council. And so those are representatives of our programs that the clients elect as officers to represent them. And I meet with them every month, and I still meet with them every month, 33 years later, so that I can make sure that I am hearing directly from our families about what is happening, whether their needs are being met, what are the ideas that they have that we might be able to change, improve the work that we do. And so that's one way. The other way is we make sure that we hire staff and that we encourage staff and train staff in this culture. And that, we call ourselves like a family organization, the Shields family. And this is the mentality that is provided to our staff, is the culture that we have, is that, family first, essentially.
Before it was the name of a law.
Before it was the name of a law.
Kathy Icenhower, co-founder of Shields for Families. Thank you for joining us on the Imprint Weekly Podcast.
Thank you for having me.
Thanks to Kathy Icenhower of Shields for Families for joining us today. The Imprint Weekly Podcast is a production of the Safe Camp Audio Network, which is a division of Fostering Media Connections. Please visit safecampaudio.org on the web or Safe Camp Audio on all social media. This podcast is produced and mixed by Christine Anjoko with music by Luke Giroux and Cyrus Elia. If you enjoyed this episode, we'd love it if you'd consider subscribing or giving us a 5-star rating on Apple, Spotify, or wherever you download your podcasts. And we'd greatly appreciate if you'd consider supporting our work here on the podcast and in print. Small donations from our listeners and readers go a long way towards helping us grow and cover more great stories in child welfare and youth justice. To support us, very easy. Just visit imprintnews.org/donate. You can follow The Imprint on Twitter and Facebook by searching the handle @TheImprintNews and visit us on the web at imprintnews.org. You can always get us on email at tips@imprintnews.org. I'm John Kelly, and we'll see you next week.